All right. Hello, everybody. Thank you so much to Jenny and Greg and Myeloma crowd for having me. It looks like we've got a really great audience here. Let me share my screen and we'll start talking about the role of Venetoclax in myeloma. Venetoclax in myeloma is very exciting. I'll just say first, and I'll probably say it 3 or 4 times in the midst of my talk, is that Venetoclax in myeloma, it remains investigational. And for the most part, the Venetoclax should be used in the context of a clinical trial. And there are probably some times that it's appropriate to use Venetoclax outside of a clinical trial, but we're still learning a lot about Venetoclax. Venetoclax is really an exciting drug in myeloma because we usually think that when our doctors decide what treatment to get, that they know exactly what the biology is going on in the myeloma cell, and we match the drug with the biology. But the reality is that we haven't done that yet. There's a lot of research into that, and Venetoclax is the first drug that starts to do that. And so that's what's so exciting to me about Venetoclax, and that Venetoclax really is the first, what to date, the success it's had to date, personalized therapy in myeloma. So we're going to talk a little bit about the biology of myeloma and Venetoclax and BCL2 inhibition, which is how Venetoclax works. And then I'm going to run through the data that we have so far for Venetoclax. All right, so we're going to go back to science class here for a few minutes. I'm going to try to walk through this so this makes sense. Venetoclax is a BCL2 inhibitor. BCL2 is a protein in the myeloma cell that prevents the myeloma cell from dying. Every cancer cell and every myeloma cell is very sick. They are very sick cells. They're not normal. And these cells want to die. And the technical term for a cell dying, or one of the technical terms for the cell dying, is this word apoptosis right here. And the cell wants to die. And there are several proteins, and BCL2 is one of those proteins that is overabundant and is acting inappropriately in a myeloma cell, in a cancer cell, preventing it from dying. And so there are different types. There are proteins like BCL2, another protein called MCL1, but BCL2 appears to be important in myeloma, particularly in 11-14 myeloma. And so I'm going to walk through this graphic here. All of these proteins, all of these things, MCL1, BCLX, BCL2, they are the proteins that are preventing the cancer cell from dying. Again, all cancer cells want to die, and it's these guys here that are preventing the cancer cells from dying. And so the reason they prevent cancer cells from dying is because they stop this protein called BIM from interacting with these proteins and then killing the cell. And so they hold on. BCL2 is holding on to BIM, preventing BIM from allowing the cell to die. And so I'll walk through here. If all of the BIM is over here on BCL2, then that's good. That is a cell that is dependent on BCL2. And if we had a drug that blocked that interaction and allowed BIM to do its job, then the cell would do what it wants to do. The cancer cell would do what it wants to do and die. And that's what Venetoclax does. Venetoclax, you'll see it takes that space, it binds to BCL2, and it allows the BIM to go do its job, and then the cell dies. So that's why Venetoclax works. It allows the cell, it stops the protein BCL2, which prevents the cell from dying, from working. And so there are some myeloma cells that don't care about BCL2 and they care about MCL1. And in those cells, venetoclax has no chance of working. And so we have to figure out which cells are more likely to be dependent on BCL2, which myelomas are more likely to be dependent on BCL2. And we had, in our laboratory, we had determined previously that it was more likely going to be the 11-14 patients. And so when we did a phase 1 study of all patients with myeloma, 11-14 means that a portion of the 11th chromosome has mixed and matched with a portion of the 14th chromosome. And that's the translocation 11-14. Now, these abnormalities are only in the myeloma cells. You're not born with this. This is what made the normal plasma cell abnormal. This is one of the early events that took the normal plasma cell from doing its normal everyday job of making antibodies and helping the immune system to turning into myeloma. And so about 15% of patients with myeloma have the 11-14 translocation, or T11-14 or 11-14. I'll just use all those terms synonymously. And you'll notice here that almost half of the patients in this study had 11-14. And you ask yourself, why is that? And the reason that is that at our site and at several other sites who knew the preclinical data, we knew that this drug was only going to work, or much more likely to work, in patients 11-14 and not others. And so if you look at the two groups of patients, the 11-14 patients, 40% of those patients responded to venetoclax by itself. And if you looked at the non-11-14 patients, it was only 6%. So we know that there's a small handful of patients, for reasons that we're working out, that will respond to venetoclax, but there's a much larger proportion of patients who respond to venetoclax by itself. And so just to give you an idea of what 40% response rate means, is that's more than the single agent response to Velcade. That's more than the single agent response to daratumumab. That's more than the single agent response to Revlimid or pomalidomide or carfilzomib or Kyprolis. None of these, and this study didn't use any dexamethasone. And so this was really exciting, because for the first time, we had predicted what would happen in the lab, and then we brought it to the clinic, and what we predicted in the lab happened to patients. And so now, for at least for the 15% of patients who have 11-14, we now have, we think we have a new treatment option. So then we asked the question, okay, it's only 15% of patients we think are going to benefit. How can we get more patients to benefit? 15% of patients even have a chance of being that 40% of patients who benefits. So a couple questions. How can we get that 40% of the 11-14 patients higher? And can we get that 15% higher? Can we say it's no longer 15% of patients who might benefit, but could there be 20%? And so we then asked the question, what can we do to make more patients sensitive to venetoclax? And this is a work done by the scientist who runs our program, Larry Boyes, and Shannon and Vikas in the lab, and myself and all of my partners in the clinic, Dr. Nuka and Dr. Loniel. And ultimately what we determined was, and I know you guys are going to be thrilled about this, the best partner with venetoclax is dexamethasone. And not just because dexamethasone is we use with everything, but very specifically, we shift more patients to be sensitive to venetoclax with dexamethasone. So, and this is the model that we have, that when we add dexamethasone, we make more patients sensitive, more of that BIM bound to venetoclax, bound to BCL2, more sensitive to venetoclax. So then we ask the question, is this really true? And we ask the question, the way to answer the question is to do a clinical trial. And so in this clinical trial, you'll see here that when we added dexamethasone to venetoclax, we went in this group of patients went to 60%. And so this group of patients was very similar to the original group of patients. They had, and where a small portion of these patients had daratumumab and didn't respond to daratumumab anymore. And this was a group of patients that was much later. They had had much more therapy. Almost 90% of these patients had daratumumab, and now the response rate is still higher with the combination of venetoclax and dexamethasone. And again, all of these patients had dexamethasone previously and hadn't responded to dexamethasone. So we think that the reason dexamethasone helped here was not because it was dexamethasone, because it was pushing more of those patients to be responsive to venetoclax. And then this is showing curves that on average, if you take the entire group, it worked for that the entire group didn't progress 11 to 12 months. And if you looked at the survival of the entire group, it was half the patients were alive 12 months later. And for this group of patients, that's better than other treatments that we've seen. We've seen some preliminary data that the combination of venetoclax was very effective with bortezomib and dexamethasone. And the makers of venetoclax designed this study, and they looked at a subgroup of 11-14, but they also looked at everybody. And so if you look at everybody, what this shows you, and we can show you by the graph or the numbers, that the average amount of time that the patients in this group didn't progress was double with venetoclax. But, and this is a really big but, the patients who were, if you look at this entire group, and this is why I'm so careful to say this drug for most patients should be treated in the context of a clinical trial. The patients actually had a decreased survival, despite the fact that the whole group did better from a myeloma perspective. There actually there was an increase in early deaths, and so the entire program of venetoclax stopped in myeloma, and we went back to the drawing board. But a very important thing to note, that if you just look at the patients who in the same exact study who had 11-14, the benefit was profound. And there was no decrease in survival. And my guess is that over time, we're actually going to see an improvement in survival. We're going to see an improvement in survival because these patients did so well. So again, very, very important that this drug, at least for right now, should be looked at in patients who we know have 11-14. And then there might be a future where we can figure out some additional patients, but for right now, it's for 11-14 patients only. And then we know we can combine it with daratumumab and dexamethasone, and I'll show you here. This is the combination of venetoclax, dexamethasone, daratumumab. 96% of the patients responded. We can do it with carfilzomib. This is 11-14 patients alone. Venetoclax, dexamethasone, carfilzomib, again, 90+%. And so, again, I'll just conclude. Venetoclax is currently under investigation in 11-14, but not yet approved. There are clinical trials that are going on that will help get this drug approved. And if you are a patient who has 11-14 and you need a new treatment, there's a lot of trials out there. There's an international study of venetoclax and dex compared to pomalidomide and dex. There's a study of venetoclax, daratumumab, dexamethasone compared to Velcade, daratumumab, dexamethasone. There's a study of venetoclax, kyprolis, dexamethasone compared to kyprolis, dexamethasone. And all of these are 11-14 only. And there's something called the MyDrug study, which is led by the MMRF or MMRC, that is looking at comparing venetoclax with ninlaro, pomalidomide, and dexamethasone to ninlaro, pomalidomide, and dexamethasone. And so again, before there's widespread use of this drug in the 11-14 patient population outside of a clinical trial, we need to do these clinical trials and resolve these safety issues. And with that, I'll end my presentation.